Uh, a very good afternoon, each and everyone. Thank you, Reddy sir, and thank you, AIOS, for giving me this opportunity. I'll be talking in brief about what the fields, how the fields talk to us, and how to infer what they actually mean in the visual fields. So first of all, there are various parts of the single field analysis. So we have the procedure information in the patient data, which is the basic data. The reliability indices, as how reliable the visual field is. Raw numeric data, that is the retinal sensitivity at each specified point. The gray scale, the interpretation of raw data in the shades of gray. The total deviation plot, which is very important to know the depth of the defect, what we have. The probability plot, the probability of this defect being present in the normal population. The pattern deviation numeric plot, the adjustment of the hill of the vision so as to bring out some patterns in the generalized defects. Again, the pattern deviation probability plot, the probability of this being normal in the normal population. Then we have the global indices, which includes the VFI also, and then the glaucoma hemifield test, which compares the superior and the inferior visual fields. We also have the gaze streaking, which is a part of the reliability data. So we move on to the next. This is the information we get from the top of the visual field. So we all know what does each these arrow points to a different part. The important part is the name of the patient and the ID of the patient, because sometimes you can have the same patient, same name patients in the OPD and you can get confused. Also important is date of birth, because it is comparing the age matched normative database, and the refractive error, because if it has not been properly put in, the visual fields will be grossly unreliable. Now we move on to the various types and strategies. We have 30-2, which involves 76 points, 6 degrees apart, testing central 30 degrees. We remove all these peripheral points. What we get is 24-2, which has 54 points, 6 degrees apart. Then we have got 24-2C, which has got a few points, 10 points added to give more weightage to the central defects. Then we have got 10-2, which has got 68 points, which are 2 degrees apart, measuring central 10 degrees. So since it is the central 10 degrees, there is no blind spot here. And also we don't have GHT and VFI in 10-2 visual fields, which is to be understood. Then there are various strategies. We can have standard, fast, and faster. All of them are getting less and less time consuming from the patient's perspective. And some of them do tend to lose a little bit amount of data, but we get nearly similar kind of effects when we move from one strategy to another. Then there are various reliability indices. These indices, they help us assess the quality of the test, as in how important the test is with respect to the patient's performance. So false positives, maybe for 15% you can accept them. False negative up to 33% we can accept them, and fixation losses up to 20% we can accept them. So this is gross. We should know that this is the upper limit of acceptance of a good reliability indices. False positive is the most important of all three. They occur when the patient is trigger happy, that is the patient is pressing the button when the stimulus is not there. Now why it is important? Because when the patient is pressing the button that he is seeing, in fact he is communicating that he is seeing, but actually he is not seeing, so we are missing out on scotomas, and in fact we are missing out on glaucomas. So they are associated with high threshold values. That means the sensitivity would be very high. The normal person cannot see, but this person is able to see. So there will be a high mean deviation, abnormally light gray scale, lengthy testing, abnormally high sensitivity will be labeled in the GHT. There will be larger defects in the pattern deviation than in the total deviation plot, because the hill will be uneven. So this is how is the upper limit. 14% can be accepted, but when we have 15%, you often have fixation losses, and this is what you come out with. So you have high false positives with abnormal high sensitivity, and you have a white scotoma like of a picture. False negative, this happens when the patient says that he has seen a lighter stimulus, but he's saying that he has not seen the brighter stimulus. Now this is not correct. So this occurs when the patient loses attention or is fatigued out. Here again the mean deviation will show a great negative, because it's less than what is in the normal population, and what we get is a clover leaf kind of a defect despite a normal OCT or a normal disc we have in these patients. Fixation losses, they measure the patient's ability to track the gaze. So fixation monitor usually is the blind spot. It is mapped early on in the visual field, because then we can track the fixation losses. Now what it does is it gives a high intensity stimulant at the blind spot, and if the patient says it has seen, that means he was not fixing at the correct point. So this is how the fixation losses are measured. There's typically we ask for a central yellow light, but they can change depending upon the type of visual field we want to do and the visual acuity of the patient. So whenever we have high fixation losses, there will be again two crosses in the reliability indices area, and there will be low test reliability with GHT being outside normal limits. Then gaze tracker, this measures the distance between the pupillary center and the corneal reflex. So what happens is whenever there is an upward spike, this talks about a gaze error, that is patient is not seeing at the place where you want to be, and downward spike is the place where it is not recordable. So occasional gaze errors will be there in the best patients you ever have. So whenever it is up, it is a large deviation. Whenever it is down, it is an unrecordable gaze. Now we move on to the raw data. Now raw data is the heart of the visual field. It is the measured retinal sensitivity in decibels at the fixed retinal points where the stimulus is projected. Now it tapers off very steeply from center to periphery, and central 4 points have to be the maximum sensitive points. Whenever we have 0 here, this is usually the blind spot, and this should be measured as 0 all time whenever do a visual field. So you see these are points which are measured as 0 and less than 0. So 0 means that the brightest stimulus is not seen by the patient, and less than 0 means that the testing is beyond the capacity of the perimeter. So it can still see, but it is beyond the capacity of the perimeter. So whenever we have any 0 in the central 8 points or the central 10 degrees, we should call for a central visual field to be done, maybe 10-2 or a macular field, to bring out these defects. Wherever we have values like less than 1, less than 2, less than 3, that means the perimeter is not able to offer the maximum intensity which it should give. That means that the bulb of the perimeter is at fault and it needs a replacement. Now we move on to the grayscale. Grayscale is the depiction of raw data into the shades of gray. So the center part has to be brightest, the central 10 degree. Now in this we can see that the upper part is not as bright as the lower part, and the same can be seen in the pattern deviation. We can see there are certain central defects which are marked in red over there. So this is very important here. So it also helps in highlighting the common artifacts, I think, which we'll have in the future further talks. Then we move on to the total deviation numeric plot. This compares the normative database with the patient's database. So normative database minus the raw data give you the total deviation normative plot. The numbers without any sign or the positive numbers indicate more sensitive points, and negative numbers indicate less sensitive points. So overall this is good for early glaucoma, but in absence of generalized depression we cannot bring out the pattern defects which are typical of glaucomas. Now we move on to the total deviation numeric plot. Now how do we derive total deviation numeric plot? So this is how we do. This is the normative database and this is the patient's database. So you can see the green one shows 30 in the normative database, but it is 30 in the patient's database also. So the value here will be 0. If it is 33 in the red as compared to 29 in the red in the patient's database, it will show you -4. And if it is 30 in the patient's database as vis-a-vis 31 in the raw database, that means the patient is more sensitive, it is +1 there. So this is how this is depicted into the hill of vision, where the red points are below the normals, green are on the line, and yellow are above, or the better sensitive points. Total deviation probability plot gives you a number attached to the pattern, the dark spot which is there, and that is the probability. So any symbol, say it is less than 0.5, less than 1, less than 2, or less than 5, signify that the presence of this is possible only in 2% of normal subjects. So there's a chance of this being abnormal is pretty high. So for this does not give you absolute scotomas here. No matter how dark the circle is, it does not give you the absolute defect. We have to go back to the raw data to find out whether it is actually 0 or not. As we can see here, these are all the defects which have less than 0.5% of probability being normal. But you see these yellow ones are not zeros, but the red ones were zeros. So again the probability is same, but they are having a different depiction as compared to what we can see. And these has a similar sensitivity, say 23 in both of them, but the lower one is far away from center, so it is less than 1% of probability, but the upper one is in the close to center, so this is less than 0.5% of probability. So a 5 decibel loss in the central visual field is very significant, which has to be taken care of. Now we move on to the pattern deviation numeric plot. Why do we need it? Because most of the times we can get in the total deviation plot, but the problem is whenever we have generalized defects, we are not able to pick up the specific defects because of glaucoma. So we require a pattern deviation numeric plot. Now how it is calculated? So it takes out the 7th best deviation from the total deviation plot and adjusts the hill of the vision to that particular point. Now how it is done? So this is the total deviation normal plot of the patient. And we see the best point is 25 and the worst point is 0. So all of them are aligned from minimum to maximum sensitivity. The 7th burst point is -2. So all of them will have 0, -2, -1, -2. So everything will be adjusted to this -2. This will be the new sensitivity which the patient will have at each particular point. And then we can have the bringing out of the defects. We can see in the total deviation plot, there is a generalized depression, but in the pattern deviation, we can see a superior arcuate, which is also reflected in the grayscale. Now we move on to the pattern deviation probability plot. Again, like the total deviation plot, again it gives a significance to each point, that what is the probability of this point being normal. So we can compare the total deviation plot and pattern deviation plot. They will be almost similar in early defects, but the problem will be in the generalized defect, where we have to bring out these defects which are more specific to glaucomas. So for like cataract, corrected refractive errors, you will have a depressed total deviation plot, but the pattern deviation plot will show up the defects because of glaucomas. Now, how the 7th most sensitive points can play a role in understanding the visual fields. So in this case, we can see the 7th point is 0 here. And there are a lot of points which are much depressed than the 7th point. So the scotoma here is sharp and deep. As compared to this, here the 7th point is -1, but there are a lot of points which are similar to -1, -2, -3. Here we have shallow defects, step formation of nasal step is there, but the other one has very sharp and deep defects. Now we move on to the mean deviation in the this thing. So mean deviation talks about the depth of the visual field defect overall. It's a global index. It's not a pattern index. So it's sum of all deviations in the total deviation plot divided by the number of points depending upon the 30-2 or 24-2. We get the mean deviation. So it can be very high in generalized defects if they are very deep, or in advanced glaucomas. But small localized defects, as I showed you in the previous one, where we had a small nasal step, it will have a low mean deviation. So pattern standard deviation, as we have already discussed, they are designed to pick up early defects in presence of generalized depression. They do not carry any sign here, and they cannot estimate the depth of the visual field. They only tell you how abnormal the visual field is as compared to the normals. So whenever we have less disparity in the deviation plot, we will have PSD in the less number. Whenever we have high disparity in the total deviation numeric plot, the pattern deviation will have a higher number. Now we can see how the pattern deviation can play a role. So in the one field on the left side, we can see the mean deviation is both the things are similar, but we can see that the pattern deviation is higher in the left side as compared to the right side, because there are a lot of uneven hill of vision. There are a lot of crests and troughs in the hill of vision. So pattern is more coming out in the right visual field as compared to the left visual field. Now we move on to the GHT. GHT gives you notations like outside normal limits, borderline, generalized reduction of sensitivity, abnormal high sensitivity, and within normal limits. Now these notations are almost self-explanatory, and we don't have to go into detail, but they have a statistics attached to it, which I think you can read on the book. Now we move on to the VFI. Now VFI is a new global metric. It represents the entire visual field into a single percentage, the normal being 100 and perimetrically blind person being 0. So it is based upon the pattern deviation plots when the mean deviation is better than 20 decibels, and the total deviation plot when the mean deviation worse than 20 decibels. It is again central weighted, because we all know that the point of fixation is center. Whenever the glaucoma threatens point of fixation, it becomes very important for us. So this is how the VFI gives you a slope. So this helps us in terms of both rate and event-based informations, how the patient is progressing. Is it a fast progressor or a slow progressor? The rate of progression does help in guiding the therapeutic intervention, and rate of change of VFI has shown statistically good correlation with all the types of glaucomas, whether it is OHT, early, moderate, or advanced glaucomas. It also gives you a statistically significant p-value, that how important this change is. So this is how we kind of interpret the whole visual field, and this is how the fields, they try to communicate to us. And I think we can try and listen to what the fields say rather than see, so that we can, understand our patient profile better. Thank you.
Thank you, Ankur.